Good evening, everyone, from a warm Friday night in Kuala Lumpur, Malaysia. My name is Pascal Alote, and I have had the privilege of directing the United Nations University International Institute for Global Health for the last 3.5 years. UNU, the United Nations University, is a brain trust to the UN system, and UNU-IIGH is the think tank on global health, bridging the gap between people, knowledge generation, policy, and action. I can say with hand on heart that with the exception of a few tricky days during the nightmare that was 2020, every day has been enriched by the wonderful team that I work with and our partners who demonstrate a shared sense of purpose and commitment. This event, the launch of the United Nations University Gender and Health Hub, is co-organized by UN Women and the SDG 3 GAP Gender Working Group. And to acknowledge the partnerships properly, this covers the Global Fund to Fight AIDS, TB, and Malaria, the World Bank, UNDP, UNFPA, the Global Financing Facility for Women, Children, and Adolescents, UNICEF, Gavi, UNAIDS, ILO, and of course, the World Health Organization. The Gender and Health Hub is co-funded by us, UNU-IIGH, and the Bill and Melinda Gates Foundation. The hub is a platform that aims to make accessible evidence of what works to make a difference in gender, broadly defined, and health, and unashamedly for women. We will use our convening function, academic rigor, and intellectual independence to develop and engage a vibrant network of policymakers, academics, and practitioners to synthesize learning and generate new frameworks and evidence on interventions that deliver results. The evidence, the analysis, and the process will be iterative, rigorous, and transparent, and available and accessible to those who need to use it to inform their everyday practice. You'll be hearing about the hub shortly, so I won't steal their thunder now. What we will do in the next 15 to 20 minutes or so is to start off with a brief conversation with 3 prominent women in global health to talk about the critical role of evidence in the effective integration of gender and health. They will draw on their experience to discuss the role of multi-sectoral partnerships to demonstrate how we are all constant producers and consumers of knowledge through our practice. It will also be an opportunity for them to share the exciting ideas towards the Generation Equality Forum and the priorities and evidence needed to support and sustain the generation equality spirit from Mexico to Paris and beyond. Before we go into the conversation with the panel, though, some brief housekeeping. I know we all have Zoom muscle memory and have dreams about being muted or unmuted at the wrong time. Nonetheless, a few Zoom platform notes. This event is available in English, Spanish, and French. Please choose your preferred language via the auditorium section on the left toolbar. In the interest of time, we will be keeping introductions short. The full agenda and speaker profiles can be accessed also through the toolbar on your left. Please pose your questions specifically in the Q&A section. It's the orange button available at the bottom right hand of your screen. We will now go into the first session with our panelists. This section, real action and investment in the effective integration of gender in health. Our 3 panelists will give their reflections on priorities, evidence gaps, and plans for the generation equality spirit from Mexico City to Paris and beyond. Our speakers are the first one, Ossa Renier. Ms. Ossa Renier is the Assistant Secretary General and Deputy Executive Director for Normative Support, UN System Coordination and Program Results with UN Women, and has held the position since May 2019. She previously served as the Minister for Children, the Elderly, and Gender Equality in Sweden, and has extensive experience in the area of gender equality and women's empowerment, having held various leadership positions in government, non-government organizations, and the United Nations. Our second panelist is Ambassador Stephanie Sedu, and she is the Ambassador for Global Health in France. Stephanie Sedu was appointed the French Ambassador for Global Health in May 2018. She headed the Women's Rights and Gender Equality Division in the Ministry of Social Affairs and Health, and later led a support mission revising bioethics law. After starting her career at the Ministry of Foreign Affairs, she joined the General Inspectorate of Social Affairs. She was responsible for promoting equality in the high authority for the fight against discrimination and for equality. She was first advisor and assistant to the head of post at the embassy in Kenya. Last and certainly not least, Dr. Carla Berdychevsky, who is the head National Center for Gender Equality and Reproductive Health in the Ministry of Health in Mexico. Since May 2019, Dr. Carla heads the National Center for Gender Equity and Reproductive Health at the Mexico Ministry of Health. She has 20 years of experience in sexual and reproductive health program and policy design initiatives in Mexico and Latin America and the Caribbean region. She has led both qualitative and quantitative research and has also conducted projects in health communications, advocacy, and multi-sector partnership building. She's a trained medical practitioner. Good evening, honorable colleagues, a very warm welcome and thank you for your time. So if I may start with Åsa, please. What do you think we need to prioritize to successfully integrate gender in the health agenda? Åsa.
Well, good morning and thank you so much for having me. This is the very last hours of the Commission on the Status of Women that we're doing this. And as you know, the topic of this year's Commission is women's leadership. And to start very early on with, to answer your question, I think that women's leadership is very important also for the topic we're talking about today, and I would like to elaborate on that. But first of all, I want to thank you so much, Professor, for having me and for organizing this with us. I also want to thank Her Excellency the Ambassador and all the colleagues and friends who have been working on this, the UNU Gender and Health Hub. I think it's extremely important. And it's also exciting because it's not only the last day of the Commission on the Status of Women, it's literally 3 days before the opening of the Generation Equality Forum in Mexico. So there's a lot going on, and in whatever we do, we need to have data, statistics, evidence. We have to know how things are and what we can do about them. And I think that this, not least the COVID-19 pandemic and its dire and enormous socioeconomic consequences, has shown us the need for gender responsive health data and also the need for a health ecosystem and health systems which are responsive to gender equality and women's and girls' needs. So without sex and age desegregated data, and without gender analysis, and also without the analysis and dissemination of the results, we cannot drive a good answer and response to the impact of COVID-19. So we need to prioritize, I think, 3 things. I already said women's leadership and part of decision making, but we also need, secondly, and there is no hierarchy between these 3, we need the uptake of gender transformative health data and evidence of what works to respond to the inequalities we see in health policy and programs. And thirdly, we need partnerships, and this is one example of that, to form alliances across sectors to advance gender in health. So we need comprehensive sex and age disaggregated data again, including on differing rates of infection, compounded with other health risks and differential socio-economic impacts. When we have that data, coupled with a gender analysis, we can shine the light on the underlying, perhaps hidden factors that need to be addressed to solve the problem and to reverse health threats. And capturing promising practices and strategies and approaches which work is very critical to be able to scale up and to actually target the problems as they are. So in March last year, as an example, we were very concerned about the absence of sex disaggregated data on cases, deaths, hospitalization, and testing in the context of COVID-19. So that's why we prioritize supporting countries to strengthen gender responsive measures and to improve data on gender in their COVID-19 responses, both immediately together with WHO, most of all in relation to the health threat as such, but also the socioeconomic consequences. And UN Women and WHO regularly update data on the health impact of COVID-19 by sex and age through a dedicated COVID-19 section in the program called Women Count Data Hub, which has become a go-to resource on COVID-19. And I'm sure all of you know, but should you not, I personally think our homepage has a lot of information and sources on this. And really having the right data has been a game changer for the Ebola response, which we had experience from. And when sex disaggregated data became available, it was revealed that women were more vulnerable due to cultural practices, for example. And we also know that during that crisis, we could see that violence levels were increasing, but we could also see that governments were not responding to a large extent to that. During COVID, again, violence levels spiked, but this time governments actually did step up, and we could show this pretty early, the need for them to do so. Now with the vaccine, it's going to be critical for data to be disaggregated in order to know who is getting the vaccines and who is getting left behind. And we've been working together with WHO and other agencies on guidelines for this. Also, all of this, we have to have data on the community level. We need to address the gender-related barriers which prevent women and girls from demanding the realization of their rights or the implementation of their rights, even if they demand them. There is today limited research on how unequal gender norms, households' responsibilities such as care work and farming may prevent women and girls and adolescent girls access to health services. We have to know more. So we have to always apply a gender lens because gender bias can always or often lead to systematic and unfavorable treatments of individuals based on structural discrimination, based on gender, based on the tradition to deny rights, opportunities, and resources. So in order to change this, as I said, we have to have women's leadership, and it must be at the front and center of global health. As you know, women are still a year later working day and night, literally to save the lives of the rest of us. They are 70% of the health workers in the world. They also work in pharmacies, labs, grocery stores, cleaning services, etc. But still, we see that women have not been asked about their demands, experiences, requirements at all proportionately in relation to the COVID responses in the countries. And also, women are still only 25% of parliamentarians in the countries. And we know that when we have more women parliamentarians, the agendas actually change when it comes to policy priority and budget allocations. It goes more towards investments in health, social protection and rights for children and women, for example. So women's participation is extremely important, and we have gone through together with UNDP how countries have responded, whether their measures were actually targeting women knowing that they were harder hit than men, but unfortunately, we could not see that this was done proportionately. Only around 20% of the measures were actually targeting women, and only 24% of the task force members. We went through the task forces in the countries, but only 24% of task force members were women, although they were both knowledgeable and hit by the COVID crisis.
Great, thank you. Thank you. Also, if I can try and get a
yes,
bit more.
Sorry about that.
From the other participants as well, that would be great.
I'm sure, absolutely.
Yes.
Thank you.
So, Stephanie, if you, from your perspective as well, the same question: what do we need to prioritize? Do you think to successfully integrate gender into the health agenda from your perspective?
Merci beaucoup, Madame la Professeure.
Thank you very much, dear colleagues. I'm going to speak in French. If you allow me, I'm very happy to participate in this event, and I'm very sorry because I'll have to leave very quickly at 2 o'clock sharp. And I would like to follow on the topic of the data, and because it's a very important question, it's a crucial question here. And the person before was very complete and very mentioned that the need to have data is very important, is primordial, and it's a strategic asset as well. So it's a subject on which we need to work. And maybe one point on the COVID-19. It is very important to not only to have data, to have analysis, but we saw that from the data that we have on the clinical way that women are less affected than men by this pandemic, which gives a better a feeling that maybe are saved from this epidemic. But we can see that this pandemic, because access to health and access to sexual health and reproduction health, and also other consequences, economic consequences, also violence, all these aspects have to be shown when we consider the crisis now, the current crisis, for this impact on women. And not only going beyond the simple data, considering the effects of the pandemic. So another aspect I wanted to mention, it's the place of women in the sector of health, which was the previous presenter mentioned that on this in France we have a number of data which are precise and updated on the place of women in this sector, which increases, like in other places in the world. We have the same trends around the world. And for 50% of women among the health staff, and also with medical doctors, practitioners, and in hospitals. But also we have also data that show that salaries are not equal, because salaries of women in hospitals, in public hospitals, are about 20% less than those of men. And these are examples. We have this type of data which are available. They are very useful. We also have data or more quantitative data on the bias against women, or on sexism, and also harassment in context of work, in health, in context of health, in health environments, with also quantitative surveys have shown that that other surveys on other topics, on the barriers, for example, the career in health environment for women health professionals, especially in maternity areas or other responsibilities, where they have other family responsibilities. So we see here that in a country like France, we have data on quantitative data, they're updated, and the two topics that we have now today, we need to use the data so that we can in order to show this data in the debate, in the political, in the public policies, and also to complete this data with more quantitative or qualitative data. We need to have more quality on those biases. And this is why on this topic of data, I didn't answer the questions. I didn't propose a wider answer to your question, but I am sure that other people will be able to reply or to answer to this point. I'm not sure if you want me to continue to hold the floor.
That's fine. That's absolutely fine. I think what it actually does demonstrate is just how important the issue of data are in trying to engage both in identifying what the problems are and in being able to address it. I think the issue that if we have a bit of time might be worth exploring a little bit further is actually the opportunities to actually analyze and do something with this data, both in program development and in monitoring what works and so on. Carla, please, the floor is yours. You work in quite a different context. We'd be fascinated to hear what it's like for you as well.
Thank you very much, Pascal. It's such a pleasure to be joining from Mexico City, given also that we are jointly working towards the Generation Equality Forum very soon. And this is such an important forum to be sharing with you some of our perspectives in terms of what it takes to actually integrate gender in health. And we see that there are various levels for how we do address these gaps in terms of acknowledging that gender equality really affects women's health at very different levels. And it goes from a personal, individual perspective to an interrelational perspective, maybe in a partner relationship, but more broadly towards a community and a societal setting. And I have to agree with our panelists that the basis to address the integration of gender in health is based on the data we do have and how we use this data. And it's really crucial to identify what the main gender inequities are through disaggregated data collection and use, not only seeing what the differences are between sex, but also in combination with other relevant social stratifiers. And as you know, in Mexico and in the whole Latin American region, ethnicity plays a very important role in terms of how it interacts not only with the gender determinants of health, but also in terms of how inequities begin to add on and combine as you disaggregate and combine these social stratifiers. For example, we do see now with COVID that there is a very important effect on maternal mortality in our women. It is currently the first cause of maternal deaths when you disaggregate maternal deaths by cause. And we still do not have, in terms of COVID, what this disaggregation means for ethnic minorities in the country. But we do know from before COVID that Indigenous women do have a threefold indicator in terms of increased maternal mortality when you do disaggregate the data. So having the data is essential, but having the data immediately to be able to make decisions and adapt your strategies, for example, in a health emergency like what we do have now, is really the basis for integrating gender in health. But then you do have other aspects, as I say, that need to be intertwined with what you do diagnose through data. And one of them that is crucial is participation of women in health-related decision-making. And you need to include these diverse groups of women in all the processes throughout when you develop a policy, but also when you implement it, when you evaluate it, to see if we are actually responding to all these subgroups of women to really be able to implement women-centered healthcare. And there is no other solution but to include them. And that from a policy level, given where I stand from, is sometimes complicated because you have to go through different levels of policy, of government, to actually include the final user of services in all this process. And capacities within health system in terms of gender equity and how health providers and health decision makers are sensible to a gender transformative perspective is also crucial, because if this is not in our minds whenever we're making decisions on a daily basis, then you do lose the importance of what these critical ingredients are in terms of really generating this transformation from the center. And finally, to say that women must be included in the rosters of health decision making in terms of being at the role of the decision maker. And as another example, I have to say that in Mexico, we have 32 states, and only 6 of these have women as health ministers, as state level health ministers, which is only less than 20% of this structure in terms of decision making and supervising what a practical integration of gender in health should be in practice. So thank you very much for the question. I think there's much more to say in terms of what we can do.
Indeed, I was about to say that I've just been told that we only have a few minutes left, which is a real shame, because I think just in your interventions, even though you were all addressing a single question, you've managed, all 3 of you have managed to weave in the critical issues of equity, marginalization, the importance of engagement with communities, challenges within the health sector, importance of participation, lack of women in political leadership positions, all of which come together that make this discussion an absolutely critical one. We will really be looking forward to what's going to be happening in Mexico, and the follow-on for that for Paris as well. So thank you very much. We have, I need to start the transition into the next session. I've been told we're very, very strict on time for this particular session as well. So I will, if I can just very quickly, having given that very, very quick fire kind of summary, also Stephanie Carla Ta. Merci, gracias, a real testament to women in leadership and how much we can accomplish when we're together. And I hope we have an opportunity, probably maybe not Mexico, but in Paris, to actually organize something with you to have a much more granular, in-depth conversation to continue. So I'd like to close off this section with a quick example, actually, that brings together all the issues that have been discussed as a concrete example, which is an opportunity to demonstrate the output, the sorts of outputs that the Gender and Health Hub can produce. And it foregrounds the importance of partnerships before I hand over to my colleague, Dr. Joanne Sandler, who is going to take the next bit. So it would have been dropped into the chat, the guidance note and checklist on gender and the COVID vaccine deployment. It was developed to inform how to address gender-related barriers to equitable COVID-19 vaccine deployment. And it was a collaborative output from the SDG 3 GAP, Gender Equality Working Group that is coordinated by UN Women and the Gender and Health Hub. Now, we know that history will judge our performance on this largest ever vaccine deployment. The reality is that we're not going to reach as many women, men, and gender non-conforming people as we should, and reap the full benefits of these vaccines unless we act on the gender-related barriers, inequities, and inequalities in vaccine information and access. The checklist provides a set of practical actions for COVAX and self-financing countries to implement to ensure gender equality and equity in the deployment of the COVID-19 vaccines. It notes, for instance, the need to ensure gender balance and representation from women's groups and marginalized high-risk groups in coordination and decision-making bodies responsible for COVID-19 vaccine, the vaccine deployment, and the need to put in place mechanisms to ensure the safety of all the vaccine deployment workforce. So I invite you to take a look at the checklist through the link in the chat. Please use it and share it widely with key partners. And the reality is, I mean, this stuff is not rocket science, but it makes a significant difference to the lives, to people's lives, and we need to get it right. COVID has already led to global regressions in gender equality and access to healthcare, and we have to course correct and set precedents on how we can practically and effectively integrate gender in future programming, policies, collaborations, and research. So, esteemed colleagues, thank you very much for participating in this panel. As I say, it was way too short, and I look forward to opportunities to engage with you further. And so to hand over now to Joanne Sandler, who will take us through to the next session to get a bit more granular in the discussions about the hub. Joanne Sandler has been working to strengthen women's rights, gender justice, and organizational change strategies in the US and transnationally for the last 40 years. She's a senior associate of Gender at Work, a global network of consultants who support organizations to build cultures of equality. She is currently the co-chair of the board of directors for Just Associates, JAS, a global organization that works with human rights defenders, and on the advisory committee for Girls Inc., Ulster County in New York. Joanne, the mic is yours.
Thank you so much, Pascal. Thank you for a fascinating panel. Thank you for your call to action. And thanks to UNU and UN Women for inviting me to moderate. Before we begin, just to reiterate, Pascal, your housekeeping announcement. To all the participants, all the listeners, please remember you can continue to direct questions to the Q&A, which is the orange button on the right hand of the screen. Also, a reminder that this is in 3 languages, English, Spanish, and French. So please choose your preferred language via the auditorium section on the left toolbar. We hope to hear from you. The conversation we're about to have, and we hope it is a conversation, including participation from the audience, is taking place at a crucial moment for gender and health, as all of the panelists in the first session have emphasized. The overall framing of this conversation will focus on what can we do more of and what can we leave behind in terms of policy, political strategies, practice, and conceptual models for integrating gender in health. And we're going to start with a short summary of a study that UNU has been leading with partners. It will be presented by Professor T.K. Sundari Ravindran. She is UNU-IIGH's Principal Visiting Fellow, also a visiting faculty at the School of Public Health, University of the Witwatersrand, Johannesburg, South Africa. The professor is going to present the Gender and Health Hub study, What Works in Integrating Gender and Health, Findings from Comparative Analysis across 5 UN organizations. And this study, which I have had the privilege to be involved in, provides a snapshot of learnings from recent successes in tackling gender inequalities. And so, Sundari, over to you.
Friends, I'm delighted at this opportunity to present before you preliminary findings from our study, What Works in Gender and Health, Lessons from the United Nations. In 2007, a review of gender mainstreaming efforts in health as part of the Commission on Social Determinants of Health observed that the progress was more like the emperor's new clothes. There was an appearance of much having been done with little progress to show on the ground. Things have changed for the better since then, and much progress has been made, especially in some areas such as sexual and reproductive health and rights, gender-based violence, and to some extent, HIV and AIDS. However, this progress is fragile, and this fragility has been highlighted over the last year by the COVID-19 pandemic, and there is an urgency to get our act together and to move forward with gender mainstreaming in health. This is the backdrop against which the study was done. The aim of the study was to distill transferable knowledge about what has worked, where, why, and how in UN institutions working on global health. Success was defined as concrete steps taken towards advancing gender equality at the organizational level or within health policies, programs, and in country health systems, current and sustained for at least 3 years, and in the context of programs contributing to empowering women and girls to challenge unequal gender norms. We present today the consolidated findings from the study covering all the agencies, with one caveat. We are not able to include findings from UNDP, the data from which are still being cross-verified with colleagues from UNDP. So here is a consolidation of findings of what are the ingredients of success, and I will delve into each of these in a minute. Successes were sustained when leaders worked closely with other feminists and with gender experts and invested in gender architecture at the headquarters, regional and country levels, and allocated dedicated funds. Appointing people with health-specific gender expertise was crucial, and parity alone is not enough. The gender experts, women or men, need to have competence in gender skills and to be supported by an enabling environment and resources. Two very good examples are UNICEF, where a leading gender expert was appointed as deputy ED. She in turn appointed a principal gender advisor to establish the gender architecture of senior regional gender advisors at the P5 level. Similarly, WHO did its best work on gender and health when it had a full-fledged women, gender and health department with very senior experts of great competence. Having an institutional mandate and a supportive institutional structure is really very important. And this also means internally identifying specific outcomes within the health sector and each technical department, ensuring links between gender team and the planning and budget teams, and building strong accountability mechanisms across all levels of the organizations. Good examples of this come from PAHO in WHO, where all technical departments and country offices had to report to executive management on progress against gender equity and ethnicity indicators. So did member states. And UNICEF's well-crafted gender action plans, aligned with their strategic plans, is very well known as the master switch that supported all other gender mainstreaming efforts in that organization. The impact of civil society is particularly notable, where agencies have leveraged the leadership in civil society to define and shape priorities and programs, have ensured local ownership and strategic position of work within national priorities and supporting feminist activism, and invested in strong partnerships with women's movements and in processes for feedback, accountability, and sustained engagement. UNAIDS, for instance, is the only agency within the UN to have civil society representation in its governing body. And there are examples across all agencies of partnerships with feminist civil society at the ground level to advance gender equality in health. However, there is clearly a risk in the choice of partners and ensuring that they provide genuine representation. The power of evidence is another major finding, and there were successes where agencies have used data and evidence to demonstrate the problem and to show what works, and where data was used for reflexive learning to steer programs towards gender responsiveness. So there are examples from various agencies. For example, WHO, its evidence building work on violence against women, demonstrated also by its recent report released this week. UNFPA has used evidence to support flexible programming in the FGM program jointly with UNICEF, and also in the way it has applied the gender marker for allocating resources for gender. And other organizations also draw on evidence for informing their programs. Last but not the least is the power of the collective. Joint efforts have been successful when they fully leverage the different roles of the agencies involved, their unique agendas, expertise, and partnerships with governments and civil society movements. Good examples of these are the UNFPA-UNICEF joint program for the abandonment of FGM, which has successfully worked at multiple levels at the policy, health sector, and community levels. And UNFPA has mustered the power of the collective in its as leader of the gender-based violence area of responsibility in humanitarian settings. Last but not the least, these successes were not easy, and where the context was facilitative, the other pieces fell in place way more easily and with reasonable effort rather than throwing up challenges. One, the UN system level commitments such as resolutions, treaty body recommendations, and conference and summit commitments by governments. The agency structure in terms of streamlined decision-making and availability of resource base enables better allocation of resources for gender, and an organizational culture of equality and respect for diversity is fundamental, because without it, all the ingredients of success may be in place, but the going will still be very difficult. What have we learned from this about what we need to do more of? We've learned that what is working is senior level gender expertise that is well resourced to implement effective programming and is integrated with budget and planning. Engagement with credible civil society expertise and representation, openness to scrutiny, and member state pressure to strengthen the mandates, interagency efforts and shared gender expertise, and generation and the use of evidence strategically to motivate, implement, and gain better understanding to scale up. But there are many things that we need to rethink and re-strategize if we need to move forward in more effectively than we have done so far. We have to set strategic priorities within the health system. We have observed the gendered impacts of COVID-19, and this is the time to prioritize entrenched gender equalities in the health system across all its building blocks and in areas of large health investments like the COVID vaccine rollout. Accountability mechanisms need reworking with indicators that capture health as well as gender equality outcomes rather than service coverage and beneficiaries reached. The gender marker should track actual expenditure rather than the budgets. And we need to reach a consensus on desired outcomes and pathways in gender mainstreaming for health. And this could bolster efforts across the United Nations, member states, and others in the global health field. We hope this will be the beginning of concerted and collaborative work across the UN system with civil society and other global health organizations for better gender mainstreaming. Thank you.
Thank you, Sundari. Thank you for that. And a lot to think about. Before we begin our next panel, we have an amazing gift, a short poetic intervention by poet, producer, and songwriter Q Maluisi, who was born and raised in Malawi. He is the recipient of the Poetry Association of Malawi's Award for Best Performance Poet in 2012, has performed in international arts festivals around the world. This is a poem that, on the power of the collective, that was especially written and performed for this occasion. So welcoming Q.
Greetings from Malawi, the warm heart of Africa. My name is Q Maluisi, and I'm a spoken word artist, and I'm going to share with you a poem titled This Road that has been written especially for this occasion. There is an old African proverb that says, if you want to go fast, go alone. But if you want to go far, go together. Each one of us has traveled down this road. We remember the inclines. We remember the burn in our legs, the stiffness in our backs, the stitch on our sides, and the compression in our chests. We remember our curiosity for what hid behind every bend. We remember the breath of relief on the slopes. We remember where we fell, and more importantly, where our courage summoned our strength to go on. We have discovered ourselves on this road. It has laid us bare, exposing our true nature. This road has taught each and every one of us lifelong lessons. It has given us wisdom. It has imparted a precious knowledge that we have kept to and for ourselves. And still, we have come this far. It is now time to no longer travel alone, but journey together. Starting here, starting now. We will journey together, celebrating how far we have come. In the face of how far we still have to go, we will journey together. With the faith of our kin, paving way for future generations, mapping boundaries, and more importantly, leading ourselves into a future without them, we will journey together. With every woman, man, girl, boy, young and old, hand in hand, side by side, leaving no one behind, we will journey together. Today, we answer the call of this road, and in unison, take the first step towards our collective destiny. Together. Thank you.
Wonderful. Thank you. Thank you to Q. We're now entering into the panel, which is focusing on solutions, drawing on the evidence base that has been built through practice, success, and failure over many years. Our research that Sundri presented in the preceding session identified, as you saw, the following ingredients for successful integration of gender in health. One was the power of leaders and gender experts. The second was the power of institutional structure. The third was the power of feminist civil society. The fourth, the power of evidence. And the fifth, the power of the collective, which Q talked a lot about. So as we listen to the panelists in the next section, we know that they will draw on their immense multi-sectoral experience to discuss how evidence and practice-based learning can truly be mobilized into policy and sustainable action for gender and health. Panelists will speak from the perspective of their distinct power to bring their unique lens to the conversation. And just to remind you again that really what we're focusing on is what can we do more of, what can we leave behind after so many years of work to amplify and accelerate the importance of gender equality in health. I'm going to introduce each speaker and then turn it over to them. So I'm not going to introduce all the speakers at once so that you remember who you're listening to. And our first speaker is Ms. Sivananti Tanentiran, and apologies if I pronounced your name incorrectly. Sivananti, hope you will correct it. Sivananti is the executive director of ARROW Malaysia, which is a regional nonprofit women's organization established in 1993. Before joining ARROW, she explored different career choices, including teaching at a university, running a magazine across 3 countries, and working for the United Nations. Sivananti is going to speak from the power of feminist civil society. So Sivananti, civil society expertise, practice, and scrutiny have played such a critical role in connecting evidence with people and policy, and also really moving the gender equality agenda. What are some successful examples where academic work, evidence, and technical approaches combined with the kind of activism and advocacy that CSOs do to influence the integration of gender in health, in policy and practice? Over to you.
Thank you, Joanne. I just wanted to say that indeed, feminist civil society has played a really pivotal role in moving the needle, in ensuring that gender has been integrated into laws and policies on health. And of course, the most successful examples I can think of are actually, the abortion law reforms that took place in Cambodia and in Nepal, where, academic evidence on policies and how the numbers of maternal deaths could be reduced by providing safe abortion services was utilized effectively by women's groups on the ground who were actually agitating for law reform. For example, in Nepal in particular, as the old law actually imprisoned women who suffered from miscarriage, women's groups also collected, the stories and the testimonies of these women to bring to highlight, the injustices under the old law. So without the power of feminist civil societies, kind of partnered with the power of data, such movement on reforming, these regressive laws would not have been possible at all. And then 10 years later, feminist civil society in Nepal actually got together with academics to kind of research and see where has the progress on this legal reform taken place. And they actually managed to collect the evidence and to demonstrate that even though the law was liberal, access to safe abortion services still remained out of reach for poor women. And this was due to the fact that service providers were enforcing a payment for the services. So through generating this evidence and advocating to the government then made available abortion services free of charge in public facilities. So in the same way, whether the issue has been about ensuring contraceptive access to young unmarried people, or providing comprehensive sexuality education, ending child marriage, ensuring equitable access to SRH services, gender data has been really vital to advancing gender in health. So, and a lot of emphasis has been given to quantitative data, which is disaggregated, which is of course important, but also is qualitative data. And this qualitative studies are able to provide insight, into actually honing the interventions in gender and health, especially in this era of inequalities. So both quantitative data and qualitative data, it also plays another important role, which is to ensure that governments are held accountable to fulfilling their commitments that they have made, at international agendas, right? Such as Cairo, Beijing, the SDGs, and of course the human rights commitments that they have made, such as Sedu and the CRC. And for us, monitoring government performance is a powerful feminist activity to actually keep governments on their toes, that they are endeavoring to fulfill the highest standard of health, which can be made available to all women and to all girls in all of our diversity on the ground.
Thank you so much, Sivananti. Thank you for highlighting the importance of stories and the importance of listening to the stories that women tell about their lives and their experiences. Next, we have Honorable Issa Mardo Jabir, who is a member of parliament in Chad. He is also the chair of the Standing Committee on Sustainable Development of the National Assembly and member of the Africa Parliamentary Forum on Population and Development. Honorable Issa Mardo Jabir is going to speak from the perspective of the power of leaders. So, Honorable Issa, from a national and regional perspective, how can leaders catalyze and sustain this momentum for the integration of gender in health policies? And what are the political nuances and policy processes that come into play to make a strategy successful? Over to you, Honorable Issa.
Thank you very much for having given me the floor here to express myself on this question, which is very important as it concerns the link with the question which I think is very important in my country and has a great importance when you know that the health, which is the main objective for the ODDs, for the number 3, for the 3, there are some elements, the fundamental elements for the human rights. And all human being aspires to, and we cannot have a development, a sustainable development without the question of health, of universal health is addressed in all its dimensions. And this is why it is recognized today. I would say unanimously the key role that the parliamentarians play in the mobilization of action, of public action. So the commitment of the parliamentarians is essential in order to maintain the energy, the political movement for the gender equality and health, and also in the elaboration of laws which favor the coherence of the policies, of the development policies. With the parliamentarians also, it's very important for the parliamentarians to advocate, to reinforce the performance of the governments. So it is something which is very important, but also to see that the demographic evolution linked to the needs of the people that we represent, and also that should be taken into consideration in the national strategies of development. Another question is the optimization of the budgets and the parliaments. have a very important role in the voting of the law, the new laws, and in controlling or to optimize the financing of the health section of the health issues. And another important point here, I would say that it's the domestication and the fact to see that an implementation of various instruments, international instruments should be implemented, which are voted by our countries and have to be put in place at the national level. And the parliament should really have a follow-up. So the role of the parliament is very important in this domain. I would like also to talk on the other question when you are following what I said, what I mentioned earlier on. The other question, the second question, comes to reinforce the first one, to say that the parliamentarians have to be engaged in the whole process and committed in the whole process from the elaboration to the implementation of and the follow-up. So upstream and downstream from the implementation is very important to ensure that the politicians, the policies at the national level can be put in place for the benefit of the populations. This is what I wanted to say. Thank you very much for your attention.
Thank you, Honorable Issa. Thank you for being so succinct and also for highlighting the importance of budgets and bringing gender-responsive budgeting to this question of what is happening in health generally, but also to COVID relief. Our next speaker is Ms. Jean Monroe, who is the Senior Manager of Gender Health Systems and Immunization Strengthening at Gavi, the Vaccine Alliance. Jean, over to you. Oh, sorry, Jean. Actually, before you start, let me frame the question that we want you to address, because you're speaking from the power of evidence and really from the perspective of helping us understand how evidence, data, and programmatic learning show what works and what doesn't work in different contexts. So in the context of COVID-19, what do we already know from the past with regard to gender-related barriers in vaccine development, and how is this going to shape the way forward?
I'm sorry, Jean, we cannot hear you.
Apologies. Thank you, Joanne, for the question. Can you hear me now?
Yes, perfect.
Okay, thank you. So I was saying that one of our significant learning is that addressing gender issues needs to be intentional. It's not going to happen just by chance. So in the aftermath of major outbreaks like Ebola, Zika, and SARS, we've seen that the epidemic has a disproportionate impact on women, girls, and additional vulnerable groups. Where gender equity is not considered explicitly in pandemic responses and vaccine deployment, these populations constantly fall through the gaps, which simply is not good enough. So 5 things that really come about when thinking about understanding and addressing gender-related barriers. And we've heard a lot about the first one, about one of the 5 crucial things is data, the importance of data. This is a critical first step in designing any intervention. We need to understand which populations are not accessing health services, where they're located, and most importantly, what gender-related barriers do they face. Collecting data on socio-demographic variables does not need to be complicated. It can be a quick, rapid exercise at community level, asking simple questions such as who makes the decision in the household, who has control over a mobile phone, and when a child is sick, who takes them to the clinic. During the pandemic, we have been working with Premise to launch remote surveys to ask these gender-specific questions. This informs interventions and monitors our impact on what can be done in real time. And building on that is the second point, that there's no one-size-fits-all approach. Given the differing perspectives that we see for income levels, customs, geography, ethnicity, race, education, no solution can be the same. And we found that using human-centered design in design interventions places the community at the heart of the solutions. For example, our data in Afghanistan showed that Nuristani mothers are less likely to take their children to get vaccinated than the Turkmen mothers. Therefore, developing interventions to address gender-related barriers needs to be context-specific. And at a very minimum, all interventions should be gender-responsive, understanding and adapting to the needs of women, men, and those with diverse gender identities. We found that these policies that do not do so can exacerbate inequalities if not carefully designed. For example, digital health innovations, which many people are pushing, but if they rely only on mobile health ownership, this can actually further a gender gap if women do not have equal access to mobile phones. The fourth point, or fourth learning that we've had, is the need for multi-sectoral engagement. So building on Q's poem, there was a line, "If we want to go far, go together." That's exactly what I'm saying here. If we want to make a long-term difference in gender and health, we need to expand our partnerships. Certainly beyond health partnerships, we need a diverse range of partners that are critical in tackling gender-related barriers. No one organization can tackle the mammoth task by itself. And it's critical that all of the actors come together, including CSO, faith-based organizations, private sector, youth groups, etc. And my final point is, Joanne, related to your first question, is about the sustainability. We need systemic changes, changes that will improve our health systems in the long run, but also break down the systemic barriers faced by women in health. Often when we're in crisis, we implement ad hoc changes, we fight fires, but we do not get at the structural causes of the fire. As we make choices about use of budgets, we need to ensure that the changes we're bringing are sustainable and address the root causes of inequalities. Thank you, Joanne. Back to you.
Thank you so much, Jean. Such an important point about addressing the root causes and dealing with systemic issues. I'm going to now invite our final speaker, Anthony Keady, who hopefully will address some of those. Anthony is the Masculinities Technical Advisor at Abad Resource Center for Gender Equality. He has been working in Lebanon for his past 13 years, piloting and promoting the concept of engaging men in ending violence against women and masculinities. He is a psychologist who is certified in conflict resolution and nonviolent activism. Anthony is speaking from the perspective of the power of gender expertise and the power of feminist civil society. And hopefully we'll also address this power of the collective question. So Anthony, what are one or two examples of successful approaches and strategies for engaging men dealing with masculinities in integrating gender in health policies? Anthony, over to you.
Thank you, first of all, so much for having me. So I do work for a women's organization, feminist organization in Lebanon, Abad, but my field of specialization is more how do we engage men for gender equality and masculinities. As many people know, patriarchal masculinities have so many adverse health effects for men and women. For men, it's the stoic lack of emotional expression, risk-taking behaviors, somatization of that stress when not expressed properly, lack of communication and resilient networks, social networks, as well as an increased propensity for suicidal ideation and completion, or for substance abuse and dependence. But even more importantly, maybe than that, is how men and the men who aspire to these patriarchal masculine ideals create obstacles for women's health. through the lack of understanding of women's different sexual health and reproductive needs, breastfeeding, cervical cancer, and the multitudes of issues of women's bodies that were never really seen as a man's issue. So at our organization, we've created several programs that we do with people in communities, other civil societies, and governmental institutions and ministries in order to have discussions and dialogue about these things, about the importance of emotional expression. Some of these are our new fatherhood training, where we were able to, through our first 2 implementations before Corona, we were able to find a statistically significant increase in emotional expression with men and their partners, since men and their spouses take this training, more increased sensitivity to women's issues, less use of violence against them and children, which is another important health aspect we haven't touched on. We have a psychological clinic that's free, anonymous, and confidential for any men residing in Lebanon, where they can come and speak about the issues that they're feeling. And from the psychological perspective, we can show them how much of the etiology of their stress and the difficulties in their life come from these patriarchal gendered ideals. And in these clinics, we mainly hope to rehabilitate men with abusive behaviors, but we also do couple and family therapy. And perhaps one of our newest programs that I'm really excited about is a new training for young men and adolescents and young girls, discussing masculinities, femininities, gender, and comprehensive sexual education. Because again, with more transparency, with more focus on the unity of our different gender identities and that gender spectrum, we can take away this patriarchal notion of taboo to discuss issues of health, specifically women's health, and with very positive health effects for men as well.
Thank you, Anthony. Such an important example, and also going to Jean's question about how do we address this systemically, addressing the system of patriarchy. If we fail to do that and dismantle that, so much of our work becomes just an uphill battle. Exactly. So really important example. Let me just ask if there are questions. We only have about 4 minutes left before we turn over to Professor Gita Sen. And so there was a question, and I'm going to ask each of you just to spend about 30 seconds if you have anything to say about this or any additional ideas. If there are initiatives for mental health or trauma recovery of violence, of survivors of violence against women, any successful examples, and also any examples you have of training healthcare providers, which are so important on the front line in amplifying a focus on gender equity and gender equality. So let me just go to each speaker for, as I say, unfortunately, 30 seconds. And I'm going to start with you, Siva. Any comments on that or anything else to kind of bring us forward based on what you've heard?
Yeah, I think definitely, the changes in domestic violence laws across the country were one of the most important where this gender data in health really made that kind of huge shift. But also in trying to actually kind of at health institution level to create one-stop crisis centers and gender sensitization of health service professionals was also one of those examples connected to the domestic violence legislative change that occurred, right? But of course, we have always got to say this gender sensitization is something that we know periodically needs to be done ever so often. It's not like a one-time thing, because as a new cadre of health workers come in, there is a periodic need to keep at it, right? Before until that culture kind of builds up in our society. So I think that would be my
Excellent, really important. This is not there is no vaccine for gender inequality, and so we need to continue to work on that. Thank you, Siva. Honorable Issa, any final thoughts in 30 seconds?
Thank you very much. I wanted to mention one point is a correlation which is very close to the human capital and development of one country. Now we are committed to various international agenda, which is sustainable development. And for 2030, we have also CIPD for the population and development. We also have the agenda 2023 for the New York, on which we are really committed for the empowerment of women, but also the development of young people. And also the question of gender is at the center of the policies of our country, Chad. The public policies of Chad puts the gender at the heart of the policies. So we have adopted 20% or 30% of women in, we have recruited 30% of women in various positions, of elected positions. So in all the nominations, in all the elections, we need to have 30% of women. It is progressive as well to be able to reach 50%. So this is very important for us. As a parliamentarian, we also have to see the access so that populations have access to services, health services, but also we have to see that these health staff have to have their work normally, so to benefit for the populations. This is what I wanted to say on top of what we have discussed earlier on. And thank you very much for your attention.
Thank you, Honorable Issa. Thank you also for reminding us how important those normative agreements are that are so deeply discussed, how important it is to bring that home to Chad and other countries. Jean, over to you. Anything to add either on the question of violence against women, training of health workers, and the power of collective impact?
Thank you. 2 quick points. Regarding the training of health workers, Gavi does support quite a bit of frontline healthcare worker training in country. We've got some good examples in India of using innovative approaches where women they are largely women, can come on and access training. But I would like to note that I think this is a big area that we could work on. The courses that I've reviewed are not very gender sensitive. They don't address supporting healthcare workers to understand gender barriers. So that is a big piece of work. Moving towards the next part of the collective, that we really do need to be working much better, closer together. And that's why I'm very excited about the UNU, the launch of the Gender and Health Hub today, because I think it is through research that they will be doing, evidence that they're generating, that we could respond better to these gender-related barriers. Thank you.
Excellent point. Thank you, Jean. And Anthony, over to you for any last thought on any of the questions on the table.
Sure. It's hard to just come up with the one, but as a women's organization, we have many shelters and women and girls safe spaces around our small country. But here, I also think it's important, and another reason why the hub is so important, an intersectional lens in looking at these things. Some of the structural issues that need to be resolved are more difficult in countries like mine, where governmental officials are known for being quite corrupt, and we've gone through our own turmoil aside from Corona this year. But one example of working with health workers and violence against women was we at Abad had developed a curriculum a few years ago about clinical management of rape. And we trained several doctors and health workers throughout the country because, again, within our health system, there isn't enough knowledge about how to actually look for signs of rape and how to respond from a medical perspective. And that's one example of how civil society and these different programs can really step in and lead the way when we're talking about health responses and violence against women.
Thank you so much, Anthony. Thank you to all the panelists for very specific examples. As everybody has said before, we could do this for another 2 days, and we've had so little time. So hopefully this is just an appetizer and there will be a meal forthcoming. It is now a great pleasure for me to introduce Professor Geeta Sen, who is going to do a little bit of synthesis, analysis, and closing. Professor Sen is the co-chair of the UNU Gender and Health Hub's Advisory Committee. She is a distinguished professor and director of the really massacre this, Ramalingaswamy Center on Equity and Social Determinants of Health at the Public Health Foundation of India. She's an adjunct professor of global health and population at the Harvard T.H. Chan School of Public Health and general coordinator for DAWN, Development Alternatives with Women for a New Era. Her work and her writing and speaking has shaped so much of what we think today and understand today about gender issues in health, reproductive health, and so many other areas. So over to you, Professor Geeta Sen.
Thanks very much, Joanne. I've been listening with great fascination. And there's so many nuggets from the panels that we've heard today that sort of stay with me. Among them, your own, Joanne, that there's no vaccine for gender inequality. I think that's a very good one. There's no quick fix, no vaccine. And if we've learned anything in the years that some of us have been at it, that is a great lesson. But we've also learned other things that I think, whether it's the 25 years since Beijing, or for some people even longer than that, whether our work has been at the global level or at the local level or at the national level. We've learned a lot. And I think in today's panels, we got a little bit of a smattering of all of those different, I shouldn't say all, but some of those kinds of learnings that are actually out there in the community. Certainly from the UNU study, we learned that something that we've known for quite some time, because the gender mainstreaming that the Beijing Platform for Action enshrined simply hasn't quite done the job in the ways that we had hoped it would. And now we have a much better fix, a better handle on why that is. And the UNU study has told us that we need the coming together of 5 things: leadership and expertise, the institutional structure to support advances towards gender equality, the power of feminist civil society, very importantly, the power of evidence, and last but by no means least, as our poet told us, the power of the collective. I think we've learned these things, and we need all of these things to be working together if we are in fact to advance in the next phase. We know that the world, and all of us, and the women of the world particularly, are going through very difficult times. Timely action will be crucial for rebuilding our societies and achieving Agenda 2030, the SDGs. One of the things that was fascinating as we held the first meeting, as we were preparing to hold the first meeting of the advisory group for the Gender and Health Hub, was the alacrity, the eagerness with which senior leaders from major UN bodies were absolutely willing to be themselves involved in the coming together of this hub. But what is fascinating about this hub is it's not just senior leaders from UN bodies, it is civil society, it is academics. So we've got in this hub, the GHH, the potential for almost a 360-degree approach towards advancing gender equality in health in the next phase. The global community will need improved evidence. It will need to optimize its investments and action plans with measurable indicators and real political commitment to systemic change to integrate gender for health equal outcomes much more effectively. Now, in doing this, the hub is going to work to amplify, not to duplicate efforts, and embody the core pillars of knowledge, of community, of hope, and of action. And a key outcome for the hub that we're all hoping we can build is a vibrant, diverse, inclusive, multi-stakeholder network that amplifies voices from the global south for priority setting, knowledge sharing, and policy engagement. We've seen in today's panels that that knowledge is out there now, and we need to take advantage to bring it together and to work together. So our focus is on collaboration, on practice-based learning, and co-production of critical analysis. We really are and will be more powerful together. So this launch for the Gender and Health Hub is just the beginning. We hope for continued engagement, and we call on all of you who are interested in advancing gender equality in health to join us, to join the Gender and Health Hub in this effort. So don't forget to visit the GHH website, the Hub's website, and to sign up. I want to thank you all. I want to thank you, Joanne, for giving me the opportunity to say these few words, and to invite everyone to be part of this exciting venture as we move forward. Thank you.